Okay, we have covered the brain, we have covered the brain stem, we have covered the spinal cord. Now what we're going to do in this section is cover that cerebrospinal fluid, that very important fluid that circulates throughout the central nervous system. But before we actually cover the fluid and where it goes, we need to talk about a couple protective tissues around our brain and spinal cord. So we'll begin there. So of course we have bones protecting our brain and spinal cord, right? We have our skull and our vertebrae respectively, but we also have connective tissues protecting these very important central nervous system structures, and these connective tissues are called meninges. And mainly they're going to be made up of collagen fibers. Remember, the purpose of collagen fibers is strength, right? They're just really strong proteins. So if you have enough of them, they will provide a protective barrier. And we have three layers of meninges. And what we call these meninges are maters. Mater refers to mother. So it's basically saying the mother layer. And I'll have the translations for each of these on the next slide for you. But working from superficial to deep, this is the order of the three meninges of both your brain and your spinal cord. So we have the dura mater, the arachnoid mater, and the pia mater. So to give you an idea of what in the world I'm talking about, take a look at the picture on the right. Really good illustration. You can see that we're looking at somebody's head, and you can actually see brain tissue. You can see the cerebrum in this pink area. So let's look at the zoomed in version. And this area that I'm highlighting in green, that is the actual cerebrum. That's a gyrus that I'm coloring in green right now. So let's work our way from superficial to deep. And what you'll see here is bone. So this area right there, that's going to be our periosteum in black right there. And then directly underneath that is our spongy bone. Remember what spongy bone looks like? It just has a bunch of holes in there, right? And that's what where our bone marrow and a lot of blood vessels are going to be traveling through. And then directly underneath the bone tissue is our first meninge, and that's called the dura mater. And I'll circle that or color that in purple. So the dura mater directly under the bone. Once again, a bunch of collagen fibers, just extra protection. You don't want your brain rattling around and hitting bone, right? It can easily bruise itself, so we protect it with these layers of collagen fibers. Directly underneath that, we have the arachnoid mater, and I'll color that in blue right next to the purple. That is the arachnoid mater. And then the reason why they call it the arachnoid mater is you can see under that first layer, we have all these, it kind of looks like spongy bone, doesn't it? We have all these kind of spider leg looking branches, or what it looks like trabeculae. So it looks like little spider legs, so they called it the arachnoid mater. And then those spider legs attach to the deepest layer, which is called the pia mater. And if you notice, the pia mater actually touches the outside surface of the brain. Or if you could say that, I guess, the visceral layer. It's actually literally touching the cerebrum. So all three of these are designed to protect the brain tissue. Let's go on to the next slide, and I'll show you what these actually translate to. So once again, these are all just membranes that help protect a bunch of collagen fibers. And you can see that the dura mater, it translates into tough mother. And it basically, once again, just those collagen fibers make it really, really, really tough. And if you have the opportunity to dissect a sheep brain, you'll get to play with the dura mater and actually cut it off the brain and kind of tear at it. And it's really, really hard. You need scissors or a scalpel. You can't just rip it off. And if you do rip it off, it comes off in one piece. It's really hard to rip in pieces or tear it apart. It's really, really neat. So embedded in the dura mater, we have some venous sinuses. Sinuses are just really, really big veins that drain blood in the brain area. And then we also have these things. This is called a falx, and we have several of them in the brain. But the falx cerebri is one big noticeable one. And basically, it's just a barrier, a partition. And the falx cerebri is one of the landmark ones that separate the left hemisphere from the right hemisphere. So the dura mater is just this really, really strong tissue, separating things, separating the bone from the brain. And you can see it right here on the right side. So here's the bone tissue, right? We have our compact bone sandwiching our spongy bone, and then underneath we have our dura mater, and you can see here is a sinus or a vein that's actually embedded in the dura mater. So we do have blood flow in this area. Going a little deeper, we have the arachnoid mater, and as you can see, translates spider web like, right? Because we have all these spider leg looking structures that I'm coloring in red on the left side. I'll do some on the right as well. And this is going to be really, really important, especially coming up soon when we talk about cerebral spinal fluid, because this is where the cerebral spinal fluid flows on the outside of the brain and spinal cord. So recall that we had that central canal in the spinal cord where I said cerebral spinal fluid is going to flow inside the cord. It's also going to flow inside the brain, but it's also going to flow around it as well. And the area where it's going to flow around it is this area right here. It's the space between the arachnoid mater and the pia mater. And then last but not least, we have the pia mater, and the pia translates as soft, so it's a little more delicate, not as tough as the dura mater. And once again, that is just literally touching the brain tissue. It's just this last little bit of collagen fiber, so I'm just going to highlight that in black for you, literally touching the cerebrum. So we do have spaces around and in between these different meninges, and some of these you may have actually heard of before. Probably the one that you heard of the most is the epidural space. And females, this can become very important before labor if you don't want to experience the natural pains of childbirth. What they can give you sometimes in certain situations is an epidural, and which basically numbs you from that area down and helps with the pain. So epi meaning above or around, so this is outside of the dura mater. So when they take that really, really long needle and they say, you know, bend your knees, tuck your knees to your chest, stay still, the reason is because if they go too far, then they actually penetrate the meninges, and that can cause some issues. So you want to make sure that it doesn't go past the epidural space. Now, this is just the area between the bone and the meninge, and it's mainly made up of fat. And then when you get past the first meninge, when you get past the dura mater and go between the dura and the arachnoid, we call that the subdural space. So sub just meaning under or below, right? So it would be between or under the dura, but above the arachnoid mater. And this is just an area that has that serous fluid, the fluid that we find between all cavities, right? We talked about the pericardial cavity and the pleural cavity and the pelvic cavity and all those cavities in chapter 1. It's the same stuff, just provides lubrication. And then last but not least, a very important space is the subarachnoid space. And that's going to be between or under the arachnoid, but right above the pia. And that's where all those spider legs are going to be found. And the reason why this is so important is because, as I mentioned, where all those spider legs are, that's where our CSF, our cerebrospinal fluid, is going to be floating around the brain and around the spinal cord. So let's move on to the next slide, and I'll show you a picture of the spinal cord and how these meninges and spaces are actually laid out. So I showed you a picture of the brain already with the 3 layers, dura, arachnoid, and pia. Now by looking at the transverse section of the spinal cord, we can identify the same structures. So if you pay attention to the lower left corner, get my left and right mixed up, lower left corner, you can see the 3 meninges here and where it's pointing to. You can see the dura mater is this kind of green line on the very outside. You go a little deeper, you have the arachnoid mater, and then you go deeper, actually touching the nerve tissue, this ventral root, is the pia mater. So then you can appreciate the spaces or these cavities. So if you look at the very top of the picture, you can see the subdural space or the subdural cavity here on the outside, this kind of green area. And then you can see the subarachnoid cavity in blue. So all of this space where there's going to be a bunch of spider legs supporting between the arachnoid and the pia mater is surrounded or floating in this cerebral spinal fluid. So there's a lot of fluid around your spinal cord protecting it. So it does have protective properties to it, but it also has nutrition properties to it. We're going to have a lot of important proteins and ions and salts that help nourish this tissue as well. Okay, so now that we know the fluid surrounding the brain and the spinal cord flows in that subarachnoid space, let's talk about the fluid that's flowing inside of the spinal cord and brain. And it's the same exact fluid. It's not a different fluid, it's just in a different location. It's actually inside the central nervous system structures. So I already introduced the spinal cord. That little tiny hole in the middle of that gray matter is called the central canal. And continuous with that central canal are the ventricles in the brain. Now, these ventricles are basically just hollow tubes where this fluid flows, and it's lined with those ependymal cells. And if you recall back to the previous chapter, those ependymal cells are those very important glial cells, supporting cells, and they have that cilia at the end of them. And that cilia beats back and forth to make sure that this fluid is flowing in the right direction, going with the current. So if you take a look at this picture, we have two views. We have a lateral view, and then we have an A to P view, anterior to posterior view. And it shows you all four ventricles and basically the flow of how this works. So what we name these ventricles, the first two are a little weird, and then it gets pretty simplistic. The first two ventricles are paired. So let me see if I can do this in black on the right picture. This ventricle right here is one ventricle, but it has kind of a twin on the other side of the cerebral hemisphere. So instead of labeling this first and second ventricle, because you can go first or second and first, they're the same thing. They're mirror images of each other. We just call them the lateral ventricles because they're on the lateral aspect of the rest of the ventricles. Because if you look at the rest of them, highlighted in red, they're going to be smack dab in that mid-sagittal line. So the first two are the lateral ventricles, and from there, they send the fluid down to the third ventricle, which makes sense. It's the third one in the order, and then it's going to go down to the fourth ventricle, and then it'll eventually go down to the central canal and the spinal cord, where it goes all the way down throughout the tissue, and it's eventually reabsorbed into what we call the lymphatic system, which we'll get to next semester. So cerebral spinal fluid flowing through all this. You do need to know the order of the fluid, and I have it written down for you in the next upcoming slides. All right, a lot of bullet points on this one. Let's just go one by one. First thing is, what makes the cerebral spinal fluid? How is this stuff being created in our body? And your answer is in that first bullet. It's called the choroid plexus. And what the choroid plexus is basically where these ependymal cells meet the capillaries in the brain. So capillaries, remember, very, very small blood vessels, and the ependymal cells are those supporting cells, also known as neuroglia cells. So what we do here is we manipulate, we're able to transfer or move ions. These capillaries are very leaky, or they have really they have these gaps basically between, we haven't really covered the anatomy of a capillary yet, but basically they're able to let things out at this specific part of the brain, and fluid and mainly electrolytes are allowed to leave and actually enter the cerebral spinal fluid this way. So if you skip down with me a little bit, you'll see that the cerebral spinal fluid is clear, and it's very similar to blood plasma, which makes sense because we're getting it from the blood. That's where the capillaries, blood is flowing in them, and then we're just taking out some of the nutrients and salts of our blood. And what you'll find out next semester is 55% of your blood is plasma, and out of that plasma, about 92% is just H2O water. So with that, if a fluid is 92% water, it would make sense that this is a clear fluid. Now, as I mentioned, it completely surrounds the brain and spinal cord in that subarachnoid space, right? So we'll draw an arrow over here to highlight that. The subarachnoid space is where it's completely surrounding both brain, brainstem, and spinal cord. And any excess or wasted cerebrospinal fluid can be absorbed. It can be absorbed eventually by the lymphatic system, but those little spider leg things called arachnoid villi is what helps with that. And the volume is really, really small, actually. It's only 120 milliliters. And you make a new batch of this stuff every 8 hours. So 3 times a day, you have brand new cerebral spinal fluid. So in a situation, an emergency type scenario where you are leaking cerebral spinal fluid, it's a matter of hours before it becomes critical. It's very, very dangerous. So if you ever have, just for reference and knowledge, if you ever have clear fluid coming out of the ears or the nose, and it's not watery, it's salty like, you need to go, and if it ever has a yellow tint as well, you need to go to the doctor fast, probably the ER faster. Just because if you are leaking this stuff, you only have so much of it in your body at a time, and once this stuff is gone, basically your central nervous system tissues start becoming dehydrated, and that can cause some severe issues. Worst headache known to mankind, also some really bad malfunctioning of the central nervous system. So as I mentioned, this fluid from the outside does protect us, that subarachnoid space. It's basically just like a nice little cushion, and it keeps the brain and the spinal cord floating inside of those cavities, inside of the cranial cavity and that vertebral foramen, respectively. But because it has so many ions and important and water, and with those ions salts, it does form a nutrition source for the brain and the spinal cord tissues. So very, very important. Let's move on to and you can actually take a look at this picture. It's a really great picture before you move on. And you can see the flow. You can see how outside the brain, you can see the arrows with the subarachnoid space, and how the tissue, or how the fluid moves. And then from inside, you can also see the third ventricle, the fourth ventricle, the part that connects the third ventricle to the fourth ventricle here, and how it goes eventually down into the central canal. So this fluid, once again, flowing outside the central nervous system structures and inside as well. So now let's move on, and we'll look at the exact order of flow through the brain and spinal cord. So here is the order that we would like you to know for the pathway of cerebrospinal fluid circulation. Remember, there are those ependymal cells that choroid plexus is kind of found throughout the ventricles. There are a lot in the lateral and the third ventricle area. There's also a little bit in the fourth ventricle too, though. But if they are created, if the cerebrospinal fluid is made at the very first part of this chain in the lateral ventricles, it starts here. And then as you can see, it moves down to the third ventricle. And then from the third ventricle, there's this very, very tiny canal, this very tiny channel that connects the third to the fourth, and that's called the cerebral aqueduct. And it's just a really, like I said, tiny, tiny channel. And then from the fourth ventricle in the brainstem area, it connects to the central canal of the spinal cord. And in the fourth ventricle specifically, we have these kind of posterior openings that allow the fluid to escape into that subarachnoid space. So the fluid is made on the inside of the brain, and then it escapes and goes throughout the outside area in that subarachnoid space. And as I mentioned, it can be reabsorbed into the lymphatic system, but it's also reabsorbed into the bloodstream as well. So make sure you know that order. Not too bad. It just basically goes, for the laterals are 1, 2, 1, 2, and then 3. And then I guess you can say the cerebral aqueduct would be 3.5. And then 4 for the fourth ventricle, and then the central canal is the fifth spot. And then it gets reabsorbed, and once again, we're making this stuff, depending on what book you read. Some books say that you make it every 5 to 6 or to 12 hours, like you make half of it every 6 hours. I was taught that it's brand new every 8 hours. It just depends. All right, so we have covered everything we need to know about the central nervous system for this chapter. Our last topic is going to be on the peripheral nervous system. We're going to cover just a tiny little bit on nerves, and then we're going to talk about those 12 pairs of cranial nerves, which will conclude this chapter. So once again, just a nice little review of the difference between the CNS and PNS. At the CNS, I'll highlight in black the best I can, drawing a straight line, maybe. There we go. Everything that's not in black is going to be part of the PNS. So everything branching, even if it's branching from the brain or from the brainstem, these are considered, if they're myelinated, they're considered nerves, and therefore they're part of the PNS. Okay, my friends, I have good news. You have to know 3 new terms, but you already know what they do based on the muscle chapter. Remember, we had connective tissue coverings protecting the outside of the muscle, those little islands of the muscles called fascicles, and then the individual muscle cells, right? And we called those mesioms or mysiums. You had the perimesium, the endomesium, the epimesium. Guess what? It's the exact same thing in the nerves of your peripheral nervous system. The only difference is instead of saying mesium, we're simply going to say neurium. But it's the exact same function, the exact same locations. So here in the notes, we're actually working deep to superficial. So to stay consistent with the notes, let's cover these. The endoneurium, just like the endomesium covered the individual muscle fiber. Check it out. The endoneurium covers the individual nerve fiber. And remember that nerve fiber or muscle fiber is the exact same thing as nerve cell. So this is what's covering the individual axon. One axon. Now, those axons are grouped into bunches and bunches of these kind of island-looking things, and you can see in the picture on the top right, you can see these several fascicles, these islands. So in that, we have hundreds and close to thousands of these axons in those fascicles, and then around those fascicles, which I just kind of colored in green, is the connective tissue, the perineurium. Now, when I say connective tissue, recall with the muscle, it's just collagen fibers mainly. And the collagen fibers are just providing strength to just protect this area. And then last but not least, going on the very outermost aspect, the epineurium, just like the epimesium covered and protected the entire muscle. Guess what? The epineurium covers the entire nerve. So if you look at the micrograph picture on the bottom right, you can see a cross-section of a nerve, and you can see the epineurium, the entire thing, in this orange color. This would be the epineurium, protecting the entire structure. And then you can see several fascicles. We'll do that in green to stay consistent. So here's a fascicle, there's a fascicle. All that in green is going to be perineurium. And then last but not least, within all of that, you can see all those crazy dots inside of there. Those are all individual nerve cells, individual axons, and they're going to have their own coding called the endoneurium. All right, let's move on to our final topic, the cranial nerves. Okay, so for the cranial nerves, what we're going to do is we're going to give you an overview or introduction right here, and then we're going to cover one at a time, tell you the number, the name, the function, and then I'm going to share how you can test it from a clinical perspective. If somebody was to have a cranial nerve lesion or a cranial nerve injury, how can you possibly diagnose that, or at least start the diagnosis process? So, with the cranial nerves, we've talked about them a little bit before, where they attach. They attach mainly to the brainstem, at least the majority of them do. There are 12 pairs, so you have a left trochlear nerve, you have a right trochlear nerve, you have a left vagus nerve, and a right vagus nerve. So there are 24 total, 12 pairs, and all those little holes, all those little foramen in the skull, we really only learned 2. We learned about the foramen magnum and the optic foramen in lab, but there are several other ones. in that sphenoid kind of occipital bone area, and that's where they pass through. And they're named and numbered based on either their job or what they supply. Like for example, the olfactory nerve, that makes sense. Olfaction is smell. The abducens nerve, that makes sense. It abducts something. But the vestibulocochlear nerve, that makes sense because the cochlea is in your ear, and this is the nerve that helps you hear. I didn't mean to rhyme, but that's what it is. Now, they are numbered using Roman numerals from an anterior to posterior aspect for the most part. So if you look at this picture on the right, what we're looking at here, this is the frontal lobe here. And then down here you can see the cerebellum right there. This would be the medulla oblongata area with the spinal, and you can see the bit of the spinal cord there. This would be the occipital lobe area right here. So we're looking at an anterior to posterior view. So for the most part, they are numbered going from anterior to posterior. Little tiny exceptions. We change directions or gears towards the middle part, but other than that, it's pretty straightforward. Now, one thing you need to know, though, is you need to know how to count in Roman numerals, at least up to 12. And if you football fans out there, you've seen these Roman numerals. For example, I don't know, I think the Chiefs just won Super Bowl 54. And you might have seen this on the field. It's on the logo. It said LIV, and that reads 54 in Roman numerals. So you just need to be able to count to 12, and it's really, really easy with the exception of 4 and 9. I'm going to walk you through that on the next slide, where I'm going to have a little bit more room to write. So bear with me just for a moment. We're not going to cover these crazy words all over the page. I'm going to teach you how to count to 12 first, and then we'll cover that. So starting on the left, we'll just do 1, 2, 3, 4, 5, 6. And then over here, we'll do 7, 8, 9, 10, 11, 12. Okay. So it kind of works like our American currency. We have pennies that equal 1. We have nickels that equal 5, we have dimes that equal 10, and they're all different coins, right? So if we have a penny or a 1, we symbolize that with a capital I. If we have a nickel, or 5, we symbolize that with a capital V. And with a 10, a dime, we're going to symbolize that with a capital X. And then they put these bars over the letters a lot of times. Okay, so with the weird exceptions, like I said, of 4 and 9, I'll put stars by them. Let's count to 12. Number 1 would just be a capital I, and 2 is just 1 plus 1. So it would just be capital I, and then with these bars around them like that. 3 would be capital I, capital I, capital I. We're going to skip 4 for now. 5 we know is V. And then 6 would be V plus 1, VI. Now I'm going to stop putting the bars on just to save time. 7 would be VII, right? And then 8 is V with 3 I's. And then when we get to 10, it's X. 11 would be XI. And I think by now you got the hang of it. 12 would be XII. Okay. So with 4 and 9, technically you could do this. With 4, you could just say I, 4 I's, right? Or you could shorten it. And in Roman numerals, they like to shorten it. What they do is they like to say 1 subtracted from 5 equals 4. So what they do is they put an I before a V. So what that's saying is 5 minus 1, or 1 subtracted from 5 equals 4. Now we can't say VI because what is VI? VI is 6. So we have to flip-flop it to make it 4. So what would 9 be? Instead of saying V and then 4 I's, let's shorten it. We would just say 10 minus 1. IX would be 9. Awesome. So now you know how to count to 12. With the Super Bowl this year, in case you're wondering, with 54, L is 50, and then what's 4? IV. Exactly. So that was this year's Super Bowl. Next year's Super Bowl would be LV, 55. And it just keeps going like that. So it's actually pretty cool. Now you know how to count in a different language, so to speak. Or at least a different numbering system. Okay, so on this slide, now we can get to what this slide's actually all about. This is a mnemonic. This is just a way of remembering the cranial nerves. We've used several of them this semester. We talked about PMAT. We talked about come, let's get some bacon with the skin, the epidermis. And this is just one to show you that the first letter helps you remember the first letter of the cranial nerve. So O, once one takes the anatomy final, very good vacations are heavenly. And you'll see that the first letter of the cranial nerve corresponds to the first letter of these words. So you'll see olfactory, optic, oculomotor, trochlear, trigeminal, abducens, and then you can see all the rest. Alright, so on the next few slides we are going to introduce the terms or the differences between a mixed nerve and a strictly sensory and motor nerve, and then we'll dive into the actual details and dump all this material on you one at a time. Okay, as I mentioned, the majority of the nerves in your body, 99% of the nerves in your body, are what we call a mixed nerve. And that means that it has both motor and sensory function. The nerves in your feet, you can feel your feet, somebody scratching your feet, or there's a stick in your shoe or something. You can also move your foot at the same time. You have both sensory and motor involved, right? And that is the case with a few of these cranial nerves, as you can see. Cranial nerves 5, 7, 9, and 10 are just like all the other nerves in your body. But there are some weird exceptions. There are certain nerves in these cranial nerves that are only sensory. They have no motor function whatsoever. And examples are 1, 2, and 8. As you'll see, cranial nerve number 1 helps you smell, and that is it. Nothing else. It doesn't move your nose. It doesn't wiggle your nose. It doesn't grow anything in your nose. All it does is it helps you smell. Cranial nerve 8, all it does, well, that's a little more complicated. Let's cranial nerve number 2. Cranial nerve number 2, all it does is help you see. It doesn't move your eyeballs. It doesn't help you blink. It just helps you send messages to your occipital lobe to figure out what you're looking at. That's it. And then, last but not least, we have motor nerves. And these just do motor function, and that's it, no sensory involved. For example, cranial nerve 4 just moves your eyeball. That's it. It doesn't help you with seeing or blinking or anything else. All it does is it helps you move your eyeball. Cranial nerve 11 helps you move your neck and shoulders. Cranial nerve 12 helps you move your tongue. It has nothing to do with taste or swallowing. All it does is it helps you move your tongue while you're chewing. That's it. So, to help you memorize which ones are which, you can memorize and look at this this area right here and just say, oh, 1, 2, and 8 are sensory, and this is this. That can be a little tricky. I would not recommend that. What I would recommend is knowing the functions by the back of your hand, but to get you started with that is knowing this mnemonic. So some say money matters, but my brothers say big brains matter most. And if the first letter starts with an S, that means it's a sensory nerve. If the first letter starts with an M, it's a strictly motor nerve. And if it starts with a B, it's a both or mixed nerve. And you can see that this corresponds with what we're saying up top. And it should be all correct, which it is. So, now that we've got that down, let's introduce the 12 pairs of cranial nerves. Cranial nerve number 1, and please notice as we're going through this, they're all going to be in Roman numerals. So cranial nerve I, cranial nerve number 1, is the olfactory nerve. As I mentioned, this is only a 100% sensory nerve, and the only thing it does is it helps you with smell, nothing else. So, why did we make you learn all of those crazy things with the ethmoid bone? Why is the ethmoid bone important? Well, check it out. We have our nice cool crista galli in the middle, and on the sides we have those cribriform plates. Those cribriform plates had those holes, those little foramina inside of them, And take a look at this picture on the right here with the cribriform plate. Look what's coming out or through the cribriform plate. It's olfactory nerve endings. Now, this stuff is branching from the brain. It's not in the brain. Look at where we're at. We're inside the nose now. So this is not brain tissue. So we do not call these tracts. They are PNS, all of these. So they are nerves. And these are the nerves that help you smell. So you need those cribriform plates. Now remember, we have this on the left side and the right side, as you can see here. We have a left olfactory bulb and a right olfactory bulb that has those nerve endings at the end. So how would you test this clinically if somebody had a cranial nerve issue? Well, you would make them smell stuff, right? Stick something up their nose, some smelling salts, some ammonia, some cleaning products, some whatever, it doesn't matter. And remember, we have one on the left and one on the right, so you'd want to do one at a time. So you'd want to have them close one nostril and smell, and then close the other nostril and smell. So that is cranial nerve number 1. Next we have cranial nerve number 2, which is called the optic nerve. Some of you may have heard of this before. This is also a 100% sensory nerve. Doesn't help you move your eyeball at all, just seeing. And as you can see, that's the function, seeing, vision. Now, real fast to show you the difference between the PNS and CNS, take a look at the picture on the right, and you can see going toward the eyeball, or directly coming away from the eyeball, this area right here is called the optic nerve. That's the cranial nerve. So it takes, and we'll learn about how this optic nerve works next chapter when we learn about all of the different photoreceptors and those cells in the retina, and we send action potentials from the eyeball down the retina, from the retina down the optic nerve. And then notice, once we get into the thick of the brain, it's called the optic tract. Now, what's the difference? Remember, a tract is found only in the central nervous system. It's bundles of axons in the CNS, where nerves are found in the PNS. So this is actually when we're in the brain, and notice where it's going. Where does it terminate? In the occipital lobe, right? That's our visual area, our visual center. So that should make sense. But when it's actually leaving the brain and going towards the eyeball, it's called the optic nerve. So how would you test this from a clinical standpoint? Well, let's make sure they can see. Make sure they have proper peripheral vision. Also make sure they do one eye at a time. Say, can you read the board? Can you read that sign out there? What does that sign read? Or hold a book in front of them. Can you read the first 2 sentences for me? One eye at a time. Cranial nerve number 3, I. This is our first 100% motor nerve. So all it does is some type of motor function. There is no sensory function with this. And you can see here would be from this picture from the underside of the brain. This would be cranial nerve number 1. Here is cranial nerve 2 area. And this would be cranial nerve 3, these little guys sticking up right there. So several different functions for the oculomotor nerve. This is actually one of 3 cranial nerves that's going to help us move our eyeball in different directions. Cranial nerve 4 and 6 are also going to help out, but cranial nerve 4 and 6 only move it in one direction. All of the other directions are thanks to this oculomotor nerve. So think about all the directions you can move your eyeball, right? You can move it up, down, left, right. You can also move them medially and inferior at the same time, so kind of cross your eyes. You can move them medially and superiorly if you're looking up at the ceiling. And you can kind of look superior and lateral and inferior and lateral too, with at least one eye at a time. So many different directions, and the oculomotor does most of that. Other cool things that the oculomotor does is, we'll talk about this next chapter, is it changes the shape of the lens in the pupil. So it helps you allow more or less light into the eyeball, but it also helps you accommodate or not accommodate. It helps you change the shape of your lens so you can see from a distance or close up. So if I'm reading a book and then somebody calls my name and I look away from the book and look out into the distance, my eyes have to adjust, right? My lens has to change shape so I can go from near vision or far vision to near vision, vice versa. So And that's what the oculomotor nerve does. It helps you make those quick adjustments. Moving right along, cranial nerve number 4 is the trochlear nerve, also a 100% motor nerve, and this is only going to be involved with eye movement, similar to the oculomotor, but it doesn't do all those other cool things with the pupil and the lens. This is just moving your eye basically inferiorly and medially, kind of helps you cross your eyeballs. And then that's really it. Please notice the Roman numeral, cranial nerve IV, so it's 1 subtracted from 5, that equals 4. Let's move on to cranial nerve 5. Cranial nerve V5 is a trigeminal nerve. This is a really cool nerve, number 1, because it is the first mixed nerve that we've come across with the cranial nerves. So this means that it kind of works like a typical nerve in our PNS. It has both sensory and motor function. And yes, you do need to know both functions. You need to know the motor and the sensory. So from a sensory perspective, a really great picture here to show you why it's called the trigeminal nerve. And the reason why is we have 3 big divisions. As you can see, here is the trigeminal nerve, and then it splits into these 3 major areas. And I guess you can, in this picture, a 4th one. But the 3 areas are the ophthalmic area, which kind of supplies your forehead eyeball region, the maxillary region, we know our maxilla bone, and then our mandibular region, we know the mandible bone. So from a sensation standpoint, this is what helps you feel your face, and you, as you can see, part of your head and scalp area too. Remember, you have this on the left and right side. So backtracking a little bit, I'm jumping ahead. With the going back to the oculomotor and the trochlear nerve, how would you test that on a patient? What you would want to do is you would want to close one eye at a time, or put a hand over the eye and make sure they can move the eye in all sorts of different directions, up, down, left, right. And then with that oculomotor nerve, you want to make sure that they can accommodate, that they can change, where they can adjust from reading a book to going far away, and going far away to a finger right in front of their face. You want to make sure their pupils are changing shape. You can also shine a light in their eye, make sure that their pupils change shape. You want to do that with both eyes and one eye at a time. So, how would you test the sensory function of the trigeminal nerve? Well, what you would do is you would take, and it's actually called a sharp dull test. You take something sharp, you take something dull, and you scrape it along their face. And with their eyes closed, ask if they can tell the difference between sharp and dull. Why do you want their eyes closed? Well, so they don't cheat, right? Because if they can tell if something's sharp or dull if you look at it. So with their eyes closed, you want to rub something sharp against their face and something dull, and make sure that they can tell the difference, or make sure they can tell at all if you're touching them. If they're completely numb, that's a problem as well. And you'll do that on both sides of the face. From a motor perspective, this nerve, take a look at the innervation in that mandibular area. There's a really, really big jaw muscle right here that helps you chew. That's called the what muscle? The masseter muscle, exactly. The trigeminal nerve innervates that, or at least this branch of the trigeminal nerve innervates it. So this helps you chew. This helps you masticate your food. So chewing and feeling your head and face are the roles of the trigeminal nerve. Moving on to cranial nerve number 6, the abducens nerve. The abducens nerve, nice and simple because the function is kind of in the name. It helps you abduct your eyeball. And that's it. It's 100% motor, and that's all it does. So you can only really test this one eye at a time, right? You can't abduct both eyes at the same time. If you can, let me know. That'd be pretty cool. So what you would do is you would just look to the left, and you would be testing your left eyeball. If you look to the left, your right eyeball would be looking medially, right? Here's your nose in the middle. So you can only test one eye at a time. And then, after you test the left side, tell them to look to the right. And you'll test this right eyeball to make sure that there's no lazy eye, or there's no shaking or anything. Make sure that they can move their eyeball laterally. Moving along to cranial nerve number 7, the facial nerve. The facial nerve is also a mixed nerve, so we have both sensory and motor function. From a sensory perspective, what it does is it helps you with taste, but more specifically, it's the anterior 2/3 of your tongue. So it's only the front of your tongue that's innervated by the facial nerve. The back posterior, the posterior 1/3, is going to be thanks to a different cranial nerve. And then from a motor perspective, it actually helps you move your face, facial expression. So this is your smiling, your zygomaticus muscles. This is going to help you move your buccinator muscles and your orbicularis oculi and orbicularis oris muscles. So smiling, laughing, frowning, all of those different expressions. Now, if you take a look at the picture on the right, what we're looking at is somebody with Bell's palsy, which means they have a lesion or some type of issue with the facial nerve on one side. So let me draw a line, a mid-sagittal line, separating it and comparing this right side of the face to the left side of the face. You can see some differences. You can see this eye on the right side is a little more droopier. You can see that the mouth is a little more droopier compared to the left. So what happens here with Bell's palsy is there's a paralysis of the facial nerve, and therefore these muscles that help you move your face stop working. They just become limp, and when that happens, everything just kind of seems to sag on that side of the face. So in a person without Bell's palsy, how would you test this on a patient? Well, you'd have to test both parts of the nerve. From a sensory standpoint, give them something to eat. Have them close their eyes. Once again, you don't want to cheat because then you don't know if there's actually something wrong or not. So give them something salty with their eyes closed and make sure that they can tell you, hey, this is salty. Give them something sweet. Give them something bitter. Give them something, what's the other one? Sour. There we go. And make sure that they can tell the difference. And if you want to be really particular, you do it on one side of the tongue and then the other side of the tongue. From a motor standpoint, just help them or have them do facial expressions. Help them frown, help them poke out their lips, help them close their eyes tightly, help them smile, laugh. Just make sure that their face moves somewhat symmetrically. Cranial nerve number 8 is called the vestibulocochlear nerve. So believe it or not, it's actually two nerves that fuses and forms into one, and we're going to talk about this nerve in detail next chapter when we get to the ear topic. But let's separate this. The vestibulo region, or the vestibular nerve, helps you with balance and equilibrium in your inner ear, working with that cerebellum that we talked about. So you can see in the picture up here, we have something called the vestibular nerve. And then we have the cochlear division of your inner ear. We have this little snail-looking thing called the cochlea, and branching from that is the cochlear nerve. And that helps you with your hearing. So what happens is these two nerves fuse together, and they create this supernerve. And that supernerve is called the vestibulocochlear nerve, also known as cranial nerve number 8. Now, in some mnemonics and in some textbooks, you'll see this as the acoustic nerve. Acoustic meaning hearing, right? But we had to change it because we learned that this nerve also is involved with balance. It's not just hearing. So vestibulocochlear, it's still 100% sensory. Okay, it's not a mixed nerve. It's 100% sensory. It's just it has two senses. It has your balance and your hearing. So at this point, it's one of two things. Either we're at the very end of the video and I'm excited to be done with this video, or I'm just really excited about cranial nerves and I love talking about them. So let's go back real quick. Cranial nerve 8, from a functional standpoint or from a clinical standpoint, how would you test that? There's several cool different tests using a tuning fork. But if you don't have that available to you, what you would do is you would have to test hearing and balance. So have them stand up and have them balance on one leg, right? Make sure that you're nearby to catch them. Make sure that you're right next to them in case there is a lesion. But if they should be able to balance on one leg at a time, or have them walk heel toe, and make sure that their balance is not affected. Have them do that with their eyes open and their eyes closed to test that integrity of that division of the nerve. And then from a cochlear standpoint, make sure they can hear. So whisper something in their left ear and make sure that they can understand you. Whisper something in their right ear and make sure that they can understand you. Make sure that they're not tilting their head when you're talking to them, favoring one side or the other. Okay, from a cranial nerve number 9 perspective, let's talk about that. Please remember the Roman numerals, IX, 1 subtracted from 10. So we're talking cranial nerve number 9. Cranial nerve number 9 is called the glossopharyngeal nerve. Very long word. Glosso refers to the tongue. Pharyngeal or pharynx refers to the throat hole. So it kind of makes sense. They're connected, right? This is also a mixed nerve. So we have both sensory and motor. From a sensory perspective, this is the other part of the taste. So the posterior 1/3 of the tongue is innervated, or taste buds are innervated by the glossopharyngeal nerve. Because remember, the anterior 2/3 was that facial nerve, that cranial nerve number 7. If you notice the note at the bottom as well, there's also another cool sensory function of the glossopharyngeal nerve. It does help with blood pressure. There's this thing called the carotid sinus, this kind of swelling in your common carotid artery. And basically, as blood is rushing through, it's a pressure reader. It's a pressure receptor, and it tells the hypothalamus and parts of your brain, it says, hey, our blood pressure is too high, our blood pressure is too low at the moment, we might need to fix this. So that's another sensory component to there. It's a blood pressure monitor. And then from a motor perspective, the glossopharyngeal nerve helps you swallow, and it helps you secrete saliva. So the swallowing makes sense. It's a voluntary, at least it starts with voluntary movement of a lot of different muscles, and then your esophagus kind of just takes over involuntarily. All right, 9 down. Oh wait, how would we test this? See, jumping ahead. How would you test this on a patient? From a sensory perspective, same thing. Put some salt or something sour or sweet or bitter on the back of their tongue and make sure that they can tell the difference between them. And from a motor perspective, make sure that they can swallow. Make sure that they can swallow. Make sure that they're, you can put your fingers on their throat muscles and make sure that they're moving synchronously or symmetrically. And also ask them about any blood pressure issues. If they stand up too quickly, make sure that they're not passing out or fainting or anything like that. Okay, 9 down, 3 more to go. Let's talk about cranial nerve number 10, the vagus nerve. Alright, y'all, cranial nerve 10 is the vagus nerve, and this nerve is absolutely crazy. We are giving you a very broad overview of this nerve. I actually have a whole book downstairs, a 150, 200 page book on the vagus nerve alone. So it does a lot of crazy cool things, and I couldn't really get a great picture without copyright infringement, so I just showed you one part of the vagus nerve here. But it's a mixed nerve. It has both sensory and motor components, and it's the most widely distributed nerve in pretty much the entire body, let alone just the cranial nerves. And the organs that it supplies it goes everywhere. It goes to the tongue, it goes to the muscles in the throat to help you swallow, it goes in the vocal cord area, it goes to your lungs, it goes to your heart, it goes to a lot of blood vessels, it goes to the liver, the kidneys, it goes all over. It goes to the stomach and the intestines as well. So we're going to talk more about this when we get to the autonomic nervous system, and we talk about the parasympathetic nervous system, the rest and digest. A lot of that's going to be with the vagus nerve, and we'll bring it back next semester too when we talk about the heart and lung function and digestion as well with the vagus nerve. So you're going to hear a lot about the vagus nerve in the next several chapters next semester. But all of those organs that I just mentioned, vocal cords, stomach, heart, liver, all those things, they have sensory receptors, right? They send messages to the brain saying, hey, this is what's going on. And they also have motor nerves going to that area too, telling your stomach, digest food faster, or telling your heart to slow down. So in this picture, what I have for you is I just have a illustration of the vagus nerve. You can see it's branching off the medulla oblongata, And it actually goes all the way down your throat area, and it actually does talk to the heart. And it tells it to, hey, slow down, you're beating too fast. So, and it also, I mean, it just spreads everywhere, all throughout the abdominal and thoracic cavity. So how would you test this? Good question. I'll get back to you. It does too many things to just narrow it down to one specific test. But if there's a specific problem with a particular organ, then you can kind of narrow it down from there. All right, let's move on to cranial nerve 11. Cranial nerve 11 is called the accessory nerve. This is a 100% motor nerve. And as you can see in the picture, it does have several different branches. Some of the branches go towards the tongue and voice box area, and it helps you with your speech production, your voice production. But then the rest of it goes to these two very, very large muscles. One, you can see the sternocleidomastoid, remember the SCM. We have the origin down here at the sternum and clavicle, and then it comes all the way up to that mastoid process area. But then we have this also huge muscle on the backside. And remember, we called that the trapezius. So those are the two main muscles that the accessory nerve innervates. The SCM and we'll say traps. So what do those two muscles do? Recall back in your muscle chapter. The SCM helps you turn your head, helps you flex your head in that kind of prayer position, also helps you laterally flex and rotate. And then the upper traps, at least, this is the accessory nerve just talks to the upper traps. It helps you shrug your shoulders. So how would you test this on a patient? One, make sure that they can talk and sing, make sure their voice box is working properly. Two, test these muscles individually. Provide some resistance. Put your hand on one side of their head and say, okay, move your head against my hand. And make sure that they can put a decent amount of force. And then do the other side. With the shoulder shrugging, put your hands firmly on their shoulders and say, okay, press up against my hands. Shrug your shoulders to your ears and make sure that they are equal on both sides and that they can do it. Okay, moving on to our final cranial nerve number 12. Cranial nerve 12 is the hypoglossal nerve. Nice, easy nerve to finish all of this out. It's a 100% motor nerve. All it does is it helps you move your tongue. And that's it. So it helps you move your tongue while you're chewing your food. Also helps you move your tongue during speech, and just sticking out your tongue. So you can see in this picture, this is a very severe case. What happened here was a hypoglossal nerve injury to one side of the body. So it was only on the left side. We're looking at the left here. Here's right. So this person had an injury on the left side, and months and months and possibly years later, that muscle starts to atrophy, right? If you don't use it, you lose it. And because the muscle was basically not being talked to by the nervous system, it just started to shrivel up and shrink. And that's what happened here, unfortunately. So remember that all of these cranial nerves are paired. So you can see the right side of the tongue looks totally fine. It is deviated a little bit due to this weakness on the left side, but for the most part, it's fine. So how would you test this nerve on a patient who didn't have this injury? You would just make them stick out their tongue, make sure that it's even, make sure that it's not moving from side to side or crooked, and then also just make sure that they can stick their tongue through their left cheek and through their right cheek, basically. Make sure that they can move it side to side, up and down. Tell them to lick the roof of their mouth, lick the bottom teeth, that kind of thing. Make sure that they can move it in multiple directions and that it doesn't cause any issues. Alright everybody, that is the cranial nerves, and that's really the whole chapter. So just a recap page here showing you a picture of the cranial nerves. We're looking at the underside or the inferior aspect of the brain, cerebellum, and brainstem area. So you have cranial nerve 1, and it goes all the way down to 12. Make sure you know the Roman numerals. Make sure you know their names. Make sure you know if it's a 100% sensory nerve, a 100% motor nerve, or a mixed nerve. And make sure you know their functions and how you would test it in a clinical environment. Alright everyone, long chapter, I know, but neuroanatomy, your brain, is kind of important, right? So let your instructor know if you have any questions, and I will see you next chapter.